All set.
Hi, and welcome to our Lunch and Learn for the month of May. My name is Marcia Proto, and I'm the Executive Director for the Connecticut League for Nursing and the Connecticut Center for Nursing Workforce. And we can't be more excited about our topic today, all about humility. Before we jump in, I'd like to ask everybody, if you're not speaking, to mute your microphone. That would be great, and provide our speaker an opportunity to have a clear lane. And I know we're going to open it up for some questions a little later. In addition, if you don't have your first and last name on your picture, if you could possibly go to the ... on the top right-hand corner in your picture when you hover over. There's something that says rename. If you could put your first and last name, this way my colleague Peggy Malik can make sure we have attendance for everybody who participated. As you know, we are offering 1 CE for today's program, so we want to make sure that we get you the evaluation as well as the certificate for your participation today. For those who aren't familiar with Zoom, what we're going to do today is our speaker is going to share her screen. And so that will be the large portion of your screen, and the pictures of all of our attendees will be on the side. So don't be alarmed. As I alluded to, we will have time for question and answers. So if you wanted to hold your question, because it may be answered as Nora goes throughout her presentation, and if it's not answered, we can have a nice discussion at the end. So I'd first like to thank all the members of the Connecticut League for Nursing Program Committee who were kind enough to look at what our needs are of our members and identify this is a perfect topic, right place at the right time. We have Dr. Kathy Murphy, the chair of the CLN program committees on, as long with many committee members. So I appreciate their volunteerism, their leadership in really moving forward our professional development series in 2022. Kim, Bish, and Heather, if you could mute, that would be great. Or Peggy, feel free to mute anybody that's not Nora, that would be great. And so as we begin our program, the workshop title is Humility in Healthcare, a Model, and it's facilitated by Nora Zinan. Nora is an associate professor of nursing at the University of St. Joseph in West Hartford. She holds degrees in nursing and public health and a certification as an advanced holistic nurse. And she has several articles on the topic of humility, and we're very excited for her to join us this afternoon and share her work. Without further ado, Nora.
Hi, Marcia and Peggy and everybody. Thank you for coming, and thank you for having me. I'm excited to be here too, a little nervous. I hope that I can do this topic justice. I'm happy to keep the conversation going about humility, which began with cultural, excuse me, I have a bad cold. I'm really afraid I'm going to go into a coughing fit. So if I turn off my mic, that's why. Hang on one second, I have to cough. Okay, so it began with the cultural competence and moved to cultural humility, and I want to, we'll go into that a little bit more, but that's what I want to continue this conversation about, humility. Let me share my slides. This topic had been burning to get out of me for quite a while, and really became forefront when my father became sick with a long-term illness. And during that several years, we had many wonderful providers who were brave and flexible and innovative and listened to us. And then there were others who were powerful, you know, who wouldn't listen. And I remember one palliative care doctor actually who came in at one point to me and my mother and really started haranguing us, about this is what we're doing, and we've done what we can, and and kept talking and talking and talking until I actually raised my voice pretty loud and said, "Now I have something to say." And trust me, I said it a lot louder than that. So it's something that I really believe can impact the quality of healthcare and patient outcomes. And we're going to talk about that a little bit more too. The other thing that was happening about the time is that there became a lot of, well, I think their news commentary shows that were pretty insulting to people in the news. And it's not something that I value by any means. I mean, I do think we need to respect all people, even if they're different than us. And then the third thing that was happening was that my nieces and nephews were coming of age, and I was starting to get a sense of that they felt that they knew more than us. And that's usually the generation, right? I mean, usually the generation, the next generation knows more than the prior generation. But what I wanted to hopefully emphasize is that they can see farther because they stand on the shoulders of the people who came before them. So I wanted them to have more appreciation of why they are so smart. And they are, I mean, our nursing students are pretty smart. So I just want people to have an appreciation of that, of the people that came before. I need to minimize this. Okay, so there is no actual standard definition of humility. I think it's important that we come to a definition if we can, because then we can research it, basically. So some people think that modesty is humility, and what I wanted to point out is the difference between the two, and that modesty usually refers to behavior and dress or accomplishments, and is a little bit different than humility. You can be humble and modest at the same time. You can dress modestly, not necessarily be humble at the same time. One of the things that I believe is that to be humble, you would need to act with humility. And that's why I break down humility into behaviors. So humility can be considered a personality trait. And it can also be, again, considered as practicing humble behaviors. I was asked once, I presented this in England one year, and I was asked, why would you want to measure a personality trait? And again, what I think is that having humility or practicing humility in healthcare can really impact healthcare outcomes. Humility is the opposite of arrogance, where arrogance is that you believe that you know more or are better than others. And what I really think is when someone is arrogant, that it puts up a brick wall, and it really closes down opportunities from learning from the other people. And we're going to talk about that a little bit more too. It doesn't mean that you subserviate yourself. So the historical meaning of low in self-regard and worth and lowly, it is not that. It is more that you appreciate that you are part of a whole, that you have your gifts, but it takes everybody to row the boat, essentially. I was asked at one point, so do you not say anything? Do you not advocate for patients because you really don't have the humility? And that is not it. Service is one of the pieces of humility. And so speaking up and advocating can be done with humility. So today, it is an accurate assessment of talents within the context of a world perspective. You are part of a whole. It is also other-oriented, and it really opens you up to learning from others. And by other-oriented, in addition to knowing that you are part of a team, part of a whole, it means that you do what you can to raise others up. Why? Why do we want to know humility? With the Affordable Care Act, navigating the healthcare system became more complex. We put in the health navigators. That was great. Probably needed them before then. It's really interesting. I was researching this a little bit more, what's been happening to the Affordable Care Act and health insurance. And there is that with that, there was a 25% decrease in people who were uninsured. However, there's still 31 million people uninsured in the United States. And when you're uninsured, then you're faced with having to choose, right? Choose between treatment and something else. So, excuse me. So I do think healthcare is, the system itself is complex. And then all of us are becoming more educated with the internet, and all of us are traveling to other countries. And so we have to welcome and approach other cultures with humility. Many people are getting frustrated with Western therapies that are not working quite as well. And so we are seeking natural, complementary, and alternative therapies. And then we've always been frustrated with the paternalistic healthcare system that basically tells us what to do rather than works with us. I didn't include this other topic, more complex diseases, in the paper, but ever since the paper was written, it's really coming out that disease is getting more and more complex. We're almost mastering cardiovascular disease and cancer. What we're not mastering is the emerging diseases like Lyme disease or Alzheimer's. I am actually working on another paper on Alzheimer's right now, and I'm a holistic nurse, and so reading about it holistically and natural therapies for Alzheimer's disease, the natural people rated as the third leading cause of death at this point. The CDC rates it as the 6th or the 7th. And my feeling is that if we can almost crack Alzheimer's disease, that we'll be able to solve a lot of problems. So what the natural healers are coming up with are that there's 4 subtypes of Alzheimer's related to infectious disease in terms of gingivitis of the mouth can contribute to it, desaturation at night, insulin insensitivity, and so it really is a complex disease, and I'm hoping that, and since disease is complex, none of us know everything, and so we really, really need to work together. So my goal in developing the model is to combine prior knowledge into a functional model that can be practiced. Suggest the need to practice the structures in order to improve healthcare decisions and promote better healthcare outcomes. Suggest strategies to practice and operationalize humility in all levels of healthcare decision-making. And those 3 levels are personal, interpersonal, leadership, systems, and policy. And again, my belief is that it will improve patient outcomes. And we're going to talk about reducing misdiagnosis and a concept called premature diagnostic closure. I also think that it has a potential to improve patient and provider satisfaction. I know that lots of providers are stuck in trying to meet productivity demands, and I'm hoping that it can actually, by having better working relationships, we can improve patient and provider satisfaction. I'd like to be able to ask questions, but we're going to keep questions at the end. I would like to be able to ask if there are any questions, but we'll keep them to the end. So as I mentioned, the model originated with the concept of cultural competence by Leininger, and that was really earlier in the 1950s and 1960s. I'm citing her 2002 article here. And then Tervalon came up with the concept of cultural humility around 1998, and we are now moving to humility. So cultural competence, of course, is having knowledge of different cultures, and you know, to a certain level. Again, nobody can know everything. And cultural humility, of course, is that you recognize that you can't know everything and about a culture, and so that you approach everyone with you know, respect, and assuming that you don't know what they need. And humility, we're going to talk about the structures in terms of asking questions, active listening, reflection. We'll talk more about that. The other origin of the model is servant leadership. And that is the concept that leaders are meant to serve the people that they are employing or leading. It's a concept that I really like. So that the leader is not for power for themselves. They are actually there to give the power to the other people. Excuse me. And then humility has been talked about more in business than it has been in healthcare. And some of the concepts that we're going to go over come from that discussion of its use in business. Excuse me. Really, I apologize for the cough. Okay, so this next concept of Chen is a Chinese acronym, essentially, for four concepts that can construct humility. And so we already mentioned asking questions, and Q stands for that, asking questions. I stands for immersion and immersion learning. I also like to think of it in terms of interprofessional learning. A is asking questions, active listening. We're going to talk about that a little bit more. And N is negotiation. And I think negotiation comes into play a lot in healthcare, and where we, again, work as partners and figure out what will work best. And it requires that you be flexible and open to being taught. So this is developed by a nurse with nursing paradigms, nursing theory, but it really is meant for it to be interdisciplinary. And I, as a holistic nurse, compare it with some concepts of holistic nursing, which we'll see later. Let me just see if there's anything else I want to say. Excuse me. So this is just a graphic of the concept of how humility is evolving. And again, it began in the 1950s with Leininger and cultural competence and cultural congruence, and then progressed to cultural humility in 1998. And now I want to keep the conversation going in terms of incorporating it into healthcare practice. Have some assumptions. I believe that all healthcare providers go into the profession wanting to actually help. And so they really do want to provide quality patient care, and the patients want quality patient care as well. I believe that healthcare outcomes are influenced by the quality of relationships between providers, their colleagues, and their patients. I believe that decisions founded in humility improve those relationships and thus the decisions. I believe that there are behaviors that can be practiced. Someone once said to me, well, aren't you born humble? And, you know, I think we train our kids in lots of different things. And one of the ways that we train them is by having them to practice behaviors. And so I do think that if you actually practice humility behaviors, it will improve humility. And then I believe that humility and practicing it can really, along the lines of improving relationships, really can develop a transpersonal, spiritual, and caring relationship. And it will promote peace in practice rather than power. And those are concepts coming from Watson and Chin. Excuse me. All right. My guiding principles are that personal humility requires a deep understanding of your place in the world and recognition of your strengths and limitations. And I think as we all age, we come to understand our place better within the construct of the worlds and understanding those strengths and limitations, and that we need to work together, basically. I like that concept because what it says is that it doesn't have to be all up to you. You don't have to be all encompassing. You can have limitations and you can work with others to compensate for that. Humility leans towards the praise of others. Absolutely. You always want to raise someone up. And then it opens you up to being teachable. If you have a mutual exchange, a transpersonal relationship, then you will be taught things you didn't anticipate that you will be taught. It's generous. Humility is generous in sharing knowledge and expertise, and of course, in providing service. And I do believe that practicing these behaviors can shape healthcare decisions. So these are the meta paradigms, and I think I like a lot of them. I like the first one best. On the left, the top left, a person is, and that is that we consider the patient to be the expert, and that the provider must become the student of the patient. And I really do like putting that patient first, and those are concepts from Tervalon and Chang. And then the environment and its influence on the healing relationships. We know that that was a big concept with Florence Nightingale. I can tell you a couple of incidences where that became impressed upon me. And one was in teaching, teaching a class and talking about how all people deserve care. And one of the short videos was on how waiting room furniture doesn't accommodate larger people. And so that kind of leads into an environment that might not be necessarily as healing. The other thing, I just showed this video to my students the other day, was on people with spinal cord injuries, and that we have to be wary of autonomic dysreflexia. And it shows people in wheelchairs, real people, and it's essentially a training video for those people on what to look for in order to not get into an AD crisis. And so it shows them actually living and working and from wheelchairs and unkicking their bags. But what it also shows is their family members and the ones who love them. And so I asked my students, what do you get out of this video? And they told me about, well, you got to make sure that the catheter is unkinked, and you got to make sure that there's no tight clothing, and you're going to watch your blood pressure. And they named all these things, and they were all great. And then I said, well, one of the other things that I get out of this is how much people live with, and then how much their family members help them to live with that. So we always have to incorporate family. And then we're going to talk about in terms of policies and facility structures that can influence the healing relationship, and whether there is space, and there usually is a space allotted in a healthcare facility for conversations with families. But does the facility offer the time to be able to do that conversation? Of course, health is the patient's state of well-being, and we know that it is influenced by the healing environment and the quality of the healing relationships. And again, nursing is a distinct practice, a wonderful field, but again, we need to work with others to bring totality to the healing relationship. So finally, here are the structures of humility, which you can also call humble behaviors. They are self-reflection and critique, asking questions, active listening, learning and teachability, praise of others, and service. Self-reflection and critique is something that I think we do a lot, probably could do more. And I think of it in particular to a difficult patient, if we're dealing with a difficult patient. I can remember that as a floor nurse, I was pretty assertive about getting people up and moving them to more independence in ADLs. And most of the time that went over very well. Patients got well quicker. Families were surprised to find their family members up in chairs. But once a family member complained about that I was pushing them too much. And okay, I can see that. That was probably the wrong thing for that family. I should have probably assessed them a little bit better. And so taking that time to reflect on that is good. The other thing is that sometimes it's just not going to work, right? That relationship just isn't going to work. And so you might need to say, I'm not real good at this. I really need you to come and take over for me so that this can be the best healing relationship for that patient. Asking questions is really important. And instead of just talking, like that palliative care doctor who just kept telling and talking and talking, I do think that asking questions should be done more. I couldn't find the reference basically, but I remember reading at one point that if you asked enough questions of a patient, you could determine their diagnosis without ever physically examining them. Obviously, we value physical examination and lab results and test x-rays. But I do think that we could ask more questions to learn more about the patient we're trying to deal with. Let me just think. There's one other thing that I wanted to talk about with that. Right. This is where, between asking questions and active listening, this is where we really want to talk about the premature diagnostic closure. This is a concept from Stone where, you know, I mean, you know, if you go to one practitioner, the silo of healthcare. So if you go to one particular practitioner, that diagnosis is going to come out what that professional specialty is, right? And then they go to another doctor, and you know, you get a different diagnosis, and you have to go to multiple practitioners to finally get the accurate diagnosis. And this premature diagnostic closure, really, I mean, it really could save healthcare costs, right? It really could decrease healthcare costs, and it could you know, make patients healthier by getting them an earlier diagnosis. So the other thing is, I was actually talking with someone in my choir last week, and they were saying how they have GI problems and they're going to a doctor, and the doctor is throwing medications at them and isn't really actively listening to them, where she says that she knows what her body needs. And so hopefully we're going to start getting practitioners who will spend the time that they need to ask the accurate questions and do active listening. We were all taught active listening as nursing students, and we know that it's, you know, paying attention, you know, facing the person, looking the person in the eye, noticing body language, all those active listening tools. I actually think we need to practice it more. Like, I almost think there should be professional development and active listening. One of the other things with active listening is not interrupting. And I know that my colleagues and I work on that all the time in our meetings, where we actively let someone finish what they're saying before we interrupt them. So that's part of active listening. And then learning and teachability is, of course, learning from your mistakes, but also being open and to what other people have to say, and trying to see things differently or from another person's perspective. And then praise of others is pretty self-explanatory, but I think a concept that might be a little bit novel is that we actually pay attention to the people who praise others and promote them, like almost in terms of an annual evaluation. Is this person a teammate that promotes the value of other people? Same thing with service. And I do think that leaders who act in a service leadership model should also be promoted, that they are the ones who should be promoted. And that service is, of course, adding value to the gifts of others. So I put these structures of humility as the pillars of a Greek temple. And so you can see self-reflection and critique, asking questions, active listening, teachability, praise of others. and service as the pillars of the Greek temple. And that has the potential to impact the things in the middle: relationships with patients, families, and colleagues, decisions, and the decision-making process. And what I want to see them is operationalized on multiple levels. So the personal, interpersonal level, the leadership level, systems, and policies. And we're going to talk about that a little bit more. As a holistic nurse, I felt compelled to compare the structures and this model with the values of holistic nursing. And so you can see core value 1 is holistic philosophies, theories, and ethics. And, based on nursing theory in particular, Leininger and Watzer are included in those theorists. So structures emanate from prior nursing and other professional research, including caring and cultural humility. So holistic nurses self-reflect, self-develop, and self-care, and those are obviously structures of the humility and healthcare model. The holistic caring process: nurses function as collaborators in the decision-making process, and this model emphasizes collaboration and reflective relationships that support a well-thought-out decision. Holistic communication, therapeutic relationships, healing environments, and culture care, obviously all elements of the humility and healthcare model, including active listening, asking questions, and valuing other people's input and perspectives. And then holistic education and research, and there is more research to be done on humility, including really confirming the structures of the model and whether they can impact decisions. I'd like to see them. These are ways that I came up with in terms of operationalizing humility structures. And there are probably more. I don't think that I'm the only good brain in the room. And so you might have other ways that these can be operationalized. But for personal, interpersonal, and levels, I put, of course, regular self-critique, self-reflection and critique. And then being able to provide humility breaks on the floor. And that could be 5 minutes, 10 minutes, whatever someone needs to be able to reflect on a situation and determine what might make it better in the moment of a crisis, for example. I do think that we should actually have professional development on asking questions and active listening. Again, I think we should reinforce that. We always want to add value to others' gifts. We want to provide service if we can. I do think that humility is not necessarily overdoing service, so to the point that you drain yourself, but certainly you need to do it to practice humility, but also to maintain your ability to serve others by not going overboard. We're all chronic caretakers, and so we do need to pay attention to the amount of care that we provide others to the compared to the care we provide ourselves. And then I want to see trust built. And I do think that these are components that can help promote trust, where there's transparent and shared decision-making, a team approach, clear information, and withholding judgments. On the systems and policies level, I would really love to see new paradigms of care. I would really love to see natural and holistic therapies reintroduced to healthcare. I belong to an essential oil nurses group, and we are trying to move essential oils back into the healthcare environment. I know many nurses practice Reiki in the hospital, and I think that those should be reimbursable. Frankly, I think that those things should be allowed and reimbursed. Let me think what I wanted to say about that. New paradigms of care. Many primary care practices, maybe not many, but some are actually offering patients a natural therapeutic regimen and a conventional therapeutic regimen, and giving them the choice. And I think that's wonderful. And now we just need the reimbursement mechanisms for that. One of the things, I'll tell you a story. I had a recent conversation with a PA, and it was about natural sleep supplements. I'm guardian to my cognitively disabled sister, and we were talking about natural sleep supplements for her. And this PA didn't think that natural sleep supplements would be relevant in any way. And really didn't really listen to me in terms of wanting her to expand her horizons, until at one point I did say, I understand you're going to prescribe what you know. I want you to start learning basically something else. All right. I want it to be to shared decision making to actually be documented. So if a decision were made about a healthcare therapy, that it's documented that all the people that were included in that decision. I want to cultivate humility by allowing time for reflection and critique, and sufficient time for patient interactions, openness to new ideas and paradigms. I did my doctoral work in bullying, and one of the things that was pretty clear with bullying and preventing it is that you needed an environment that supported anti-bullying efforts. Once those anti-bullying efforts went away, bullying restarted. And so I really do think that you need a culture in a facility that allows for the humility behaviors to be practiced. And I think that, again, with productivity demands, sometimes there isn't sufficient time to ask all the questions and do the active listening that you need to do. But I would love an organization that would allow sufficient times for that. Obviously, we want to reward actions that lift up others and provide service. I do think humility behaviors could be included in annual review tools. And again, the people who support that can be promoted. We already evaluate patient satisfaction and make changes based on that. We are forced to by reimbursement mechanisms, but I think we all have a vested interest and sincerely want to make things better for patients. And again, I want to see development of reimbursement mechanisms for alternative therapies and new paradigms. And I want to begin evaluating the effect of a regular practice of humility behaviors. So now I have an activity. I'm not exactly sure how to do this to get input. I don't know if people can be unmuted, but I think what I'll do is I'll go through some situations and we can decide whether it is humility, modesty, pride, and arrogance. Marcia, do you know if any conversations possible?
So you have two schools of thought, Nora. You could have people put in the chat and we could monitor the chat, or you could just have a raise of hands if they want to do reaction, or verbal sharing, whatever's comfortable for you. And I think we have enough time. We have about 15 minutes left.
I would love it if it was verbal. By sharing my screen, I don't actually see anything else but my screen. And so it would have to be either verbal or someone would have to read the chat to me.
So I think verbal and engagement of some of our participants would be nice to hear their voices. And if you wanted to make the view of the screen shorter, if you're a participant, if you put your line next to the row of pictures on the side and drag to the right, you'll see a line that you can actually drag across, which makes Nora's screen much smaller, and you could see all of our smiling faces. So I just did that. So I'm seeing all of your beautiful faces and a small screen of Nora's presentation. So Nora, I can read the chat or read people's hands, your choice.
We might need to do both. Some people don't want to verbalize, so you might need to read. So I started thinking of examples of different situations that I've encountered, and it was really interesting that I could go on and on. I mean, I could just keep coming up with more. And you've probably already experienced some of situations where you would determine them as one of these things. So let's go through some. Here's an example. I already told you this situation, but it was with a PA, and the NP was actually open to agreeing to learn about natural sleep supplements because her patient would like to use them instead of Ambien. And would you consider that humility, modesty, pride, or arrogance?
We have some things going in the chat. Humility.
Yeah,
Humility.
absolutely. If you are open to learning about new supplements, I actually sent this NP all the information on this natural sleep supplement. She was open and she did prescribe it. And then she left the practice and the PA came on, and there are wonderful PAs. I'm not saying PAs in general, but the PA was not as open to learning about natural sleep supplements. All right, next one. A palliative care MD berates a family for requesting further services because this is what I've prescribed.
I'm watching the chat. I see arrogance from Kathy Murphy, arrogance from Diane.
Right.
Cassie, Jessica, arrogance, arrogance. Yes.
Yeah, absolutely. All right. A nurse manager proposes to a nurse that she needs, that she knows needs an emotional boost, a special task that can benefit the whole unit, accompanied by a temporary decrease in patient load. So somebody had a death in the family, somebody's husband died, but they need to keep working. And what do you do with that person on the floor?
This is a slow to respond, so it's a toss up. We have humility from Elizabeth. Another
so humility. Anything else coming up besides humility?
Not that I see in the chat.
Yeah, this would be, to me, considered service to your employees and really supporting them and raising them up. So I do consider that to be humility. And
we have the great kindness and service. Excellent. Thanks, Elizabeth, for chiming in.
Yep. All right. A nurse takes a break from a difficult patient interaction and reflects on her role and how to improve their situation.
We have humility, we have modesty. Humility.
Well, yeah, I would consider it to be humility, and I'm not necessarily right. You can consider it to be modesty as well. I would consider it to be self-reflection, one of the structures of humility. Yeah. A nurse is promoted to VP of QA over two of her colleagues and is grateful for her success.
We have modesty. We have a pride that came into me personally.
I actually think that it is pride, and pride typically gets a bad name. But I do think that pride is okay as long as it's not, put over other people, held over other people. Yeah, gratitude is certainly, an element of modesty.
Self-reflection also came up as well.
Self-reflection, nice. All right, a primary care practitioner spends a few extra minutes exploring the patient's understanding of their disease and treatment.
Active listening, we have humility. So we have some nice characteristics being shared. Active listening, yep.
Yep. A nurse leader credits the success of her program to the initiative of her employees.
We have some pride. We have modesty coming to me directly. Praise, pride.
Praise of others. Yep. Praise of others is a humility structured. It can be all of the other things that you said. A primary care practice decides to offer patients a choice between a natural healing regimen and a conventional regimen and establishes fair payment option because more patients want that option. I think that's part of humility, and in terms of teachability, basically, or basically opening options.
We have a learning and service and patient focused.
Very good. Yep, wonderful. The Center for Medicare Services provides a reimbursement structure for practices that offer natural healing regimens. To me, this is operationalizing humility, both 8 and 9, on a systems level and policy level. A psychiatrist prescribes only the medications they know and is not willing to learn about other options.
We've got arrogance, arrogance.
Arrogance, absolutely.
Nora,
The team is around. What?
I just want to interject. What I did really love what you highlighted was in 8 and 9, it's a systemic adoption of humility behaviors systematically. So it's just fantastic.
Yeah. A team is arranged that includes the patient, their family, their nurse, social work provider to listen to the patient's goals in receiving care.
We have humility coming back at us.
Absolutely.
Service, Ellen. Yep. Humility.
Asking questions, active listening, all of that. That's a tough one.
Could you read that if someone's minimized their screen, please?
A nurse allows a colleague to get credit for a QA project that she proposed.
We've got modesty here.
Yeah, I think it's a difficult one. And, you know, if you remember, I talked about how humility doesn't mean that you become the doormat, right? And so if you expect to be, well, not expect, but if you deserve to be given credit for a project, then do you speak up about it? I know that in the academic environment, it seems to be that you need to promote yourself quite a bit, right? And this is not necessarily promoting yourself as it is, you know, equalizing the field. So I think in this situation where improper credit is given to the wrong person, that it becomes the responsibility of the leader to actually make sure that proper credit is given where it is due. So I think this is a really tough one, and, you know, a situation that I think we get all the time.
And we had Diane reflect on that, you know, modesty, but not in a particularly healthy form. Isn't that interesting? Great.
Right. Right. So I'm going to skip over this. This is what I thought it was, but again, you probably, it's not my opinion that matters. Okay. Just moving on, these are the benefits that I think we can get from practicing these behaviors, where I think the self-reflection and critique, active listening, asking questions, and teachability can increase knowledge and understanding, remove barriers, expand possibilities, improve decision-making, and praise of others and service will foster teamwork, empower and develop others, distribute leadership, inform decisions and decision-making, and I think can improve satisfaction too. There are forces that favor humility. Let's see what time we're at. Ooh. And they are, again, things that need to be set up with within the facility and within the environment in which we want to practice humility. So longer patient visits, family conference rooms, diagnostic humility, where you really rule out everything else before you come to a conclusion. Forming partnerships, a regular practice of self-reflection and critique, and a culture that supports and promotes the structures of humility. And of course, there are barriers because there are lack of opportunities for self-reflection. There is paternalism and patriarchy in the healthcare system. There are productivity demands and time constraints. And then, you know, again, since disease especially is so complex, there really is a lack of provider knowledge regarding all the possible factors that can influence health. And therefore, ask questions. There's lack of a corporate culture that fosters humility, and there's a lack of study on humility. So our future research then is to really develop tools that can measure humility on all the levels that we've come up with. There are probably other operational methods. And someone, it would be great if someone could imagine those or and research them. I would love to be able to measure the impact of practicing humility on patient outcomes and healthcare costs. And then when I presented this at the first dual nursing theory workshop, someone actually said, well, I can actually conclude this in simulation, practicing this. And so it's possible that we could also include it in simulation and nursing education. And just some memes to leave you with. Humility doesn't mean thinking how low you are. It means realizing how wonderful all these other people are. Humility leads to happiness because it makes you teachable. Leaders with humility recognize that they are no better or worse than other members of the team. A humble leader is not self-effacing, but rather tries to elevate everyone. I love this. Be like the bamboo, that the higher you grow, the deeper you bow. And my final one is practicing humility is really a practice of humanity. And that's it.
Thank you so much, Nora. We'd love to open it up for questions. We have a couple more minutes. If there's some things that are important to you, sharing with your students, providing to your colleagues, would love to hear any feedback. Please feel free to unmute yourself. Elizabeth. Liz.
I find it interesting that sometimes it depends on maybe the intentions of the person reacting to humility. I find that in practicing humility, sometimes it's met with some mistrust, like that I'm not being sincere. In fact, I had a former boss years ago say, nobody's this nice and I don't trust you. I'm like, well, I don't.
Wow.
It was quite a learning moment for me. A bit of a, I don't know, it was not just a slap across the face, it was a slap across my soul, really, because I had pure intentions as a new nurse leader. And
right. I don't know if anyone else has comment on that, but of course, that was that person's own issue, right? And
but
certainly,
I find it interesting that
yeah,
sometimes humility is not met with, oh my gosh, this is refreshing, this is a safe place to be, but
right.
met with mistrust. I don't know, pretty rough.
And it's too bad that pure intention was not elevated, right? Not praised, not, yeah.
No, in fact, it was the source of my demise in that organization, which was what needed it. What's that? It was.
I just wanted to say thank you for having that pure intention.
I wasn't going to stay in a place that didn't trust humility, I guess. I don't know, or didn't believe in it.
And Nora, this is Marcia, having done a lot of work with leadership and emotional intelligence and the impact of emotional intelligence attributes and behaviors on safe and quality care and positive patient outcomes. I do see some threads based on the variety of your slides as it correlates and directly impacts emotional intelligence of an individual and a team to work with patient population. So interesting. Thank you. Anyone else? Feel free to unmute.
I have a question.
Ellen, yeah.
Hi. Just have a question for Nora. How does one of us become a holistic nurse? How do you go about that? I'm quite interested.
Well, I went through a center, it was in Florence, Massachusetts, and they conducted programs, but it's been distributed now. The responsibility for becoming certified is given to the American Holistic Nurses Association. And so if you go to that website, that's where you would, find out where the program is. But I know that there are nursing education programs that offer certificates, and we're looking at that in terms of University of St. Joseph becoming endorsed as a holistic nursing program and being able to, and UConn, there's a program at UConn as
Okay.
well.
Okay, thank you. And also, I'm looking at all these wonderful concepts and everything that you're presenting today in terms of students, teaching students, and in terms of humility. And I'm a country music fan, so I keep going back to the song "Humble and Kind." Always be Tim McGraw, "Humble and Kind," which actually
Yes.
one of our cohorts was going to use that as their pinning song, "Humble and Kind." And I just keep going back to that song. So thank you.
Yeah. Great.
Thank you for all your information.
I'm going to go play that song now.
Nora, we're almost at the 1 o'clock bewitching hour. Does anybody have any burning questions? As we shared initially, since we've recorded the session, my colleague Peggy Malik will share with you an evaluation for today's session. And when you complete that, we'll give you the certificate as well as a link to the recording, just in case you wanted to pull references off, and you'll have the slide deck as well. Kathy Murphy, Chair of our Program Committee for CLN, anything that you wanted to share as we wrap up our hour?
No, I wanted to thank Nora. I was just putting in the chat that you've given us a lot to think about, and I'm thinking about how I can integrate this in with my students to increase their humility and in talking with patients, because there's so much value in learning about different cultures and lives. And it's humanity. It's part of your day, and learning a little bit more about your patients, and then can provide you the opportunity to build a plan of care that really is individualized for them. It's so important.
Beautiful. Yeah, absolutely.
Nice summary, Kath. Thank you. Thank you. If there's not any other burning questions, we will bring our meeting to a close. Nora, do you have any final word before we log out?
No, I thank everybody for coming and your participation and listening.
And thank you so much for sharing your work and your research. And I think this is, as you alluded to right in the outset, a major concept, construct, et cetera, that we really need to start threading through all of our education, from pre-licensure to doctoral. So I can't thank you enough for your time and joining us at the Connecticut League for Nursing. So with that being said, I'm going to have Peggy stop the recording, and then we will say bye to everybody. And so have a fantastic week. Thanks for joining us.
Thank you, everyone. Bye.
Bye.